So next up, we have Robin Curnel. Robin Curnel is one of our HIT advisors here at the Kentucky Regional Extension Center. She's going to be talking about Medicare promoting interoperability for hospitals. And so, and then right after that, we're going to have Amy Daly talk about HIPAA privacy and security incident response. So Robin, come on up.
Thank you. So thanks for hanging out. I know it's getting to be a really long day and I appreciate it. We've already had some folks leave, but that's okay. That happens in the afternoon. I generally try to start this out with just like a recap of this morning, but there was so much. But when he put that picture up of the Challenger crash, I was like, wow, I know where I was. And I can't believe I'm old enough to say I know where I was, but I know where I was. Yeah. I'm sure so many of us were. And then I got nosy and I had to look some more info up on him. But yeah, 7 kids, 17 to 64. And he's 88. I mean, he's clearly brilliant, but but yes, clearly brilliant. But I was just I was like, 2 was enough. That's all I got. Don't need any more. That second one did me in. So, all right. So we're going to talk about Medicare PI. Am I too loud? Not loud enough? What am I? Am I good? Okay. Because, I'm a mama too. All right. So I guess I should use this. All right. Quick agenda. So in all honesty, I have 30 minutes and 20 of that is presentation and the other part's awards. So consider that good. Otherwise, you got Miss Amy coming after that, and she's a lot more animated. Well, I mean, you're right. You never know. So Medicare PI. So I'm going to talk about the hospital program for promoting interoperability. This morning, we had Jessica and Vance talking more about eligible clinicians and under the MIPS program and that whole set of laws. But here is the hospital side. They are very similar, but yet still have some differences and nuances that go along with it. So real quickly, the changes that occurred from the IPPS rule in 2023, the query of the PD&P measure is now required. It's still yes or no. Health information exchange, we still have our standard measures, but they had also added an optional measure to report TEFCA, which is similar to what's in our MIPS program. Then we have public health and clinical data exchange objective. So for hospitals, you have to submit a yes for 5 measures versus with MIPS only 2. And then they've added the option 1 and option 2, which is a little bit of different. You have to report what level you are participating at for this year. Scoring is a little different as well. For hospitals, they have to have a minimum of 60 points. You can have up to 100 possible. It is performance-based, so depending on how you meet the measure, will determine what your final score is. They also did some restructuring within the scoring, so they moved some measures around as far as how much weight they carry in that final score, which is similar to what they did under MIPS. And then with hospitals reporting of ECQMs, this is not performance-based where it is for MIPS, but for hospitals, they have to submit at least 4 quarters this year. They added a couple measures for folks to report on voluntarily. And so the big change for this year was the 4 quarters of reporting versus 3 in prior years. And then in pure CMS fashion, they always add something else. And so they gave us an insight that we were going to have this antimicrobial use and resistance surveillance measure added, which, hello, y'all been reporting to NHSN for a long time, but now we're going to make it mandatory. because not everybody is reporting. They also made changes to limit the duration of time for active engagement to 1 year, which means since the inception of the program, folks have signed their participation agreements with CEHRT. There's one time. I told them I'd announce it a bunch of times. Yay. So you've signed your participation agreements, but a lot of folks have kind of stayed in that mode. They've never actually went live. And so now CMS is saying, can't do that any longer. So Christina, who is actually our team lead for the Hospital Promoting Interoperability Program, I'm her partner, she and I have coined the phrase live by 25. So now any new public health measures that they add, you've got 1 year to be in that option 1 of participation and testing, and then option 2 for the next year, for the next reporting period. And then they've also added for 2024, instead of reporting 4 ECQMs, now you got to report 6 next year. So just to not really go back, way back in the history banks, but Brent mentioned it this morning, the REC's been around since 2011 with the High Tech Act. And of course, that's when these programs started for the Medicare Promoting Interoperability Program. And so, of course, it was around advancement of EHRs. They wanted folks to start communicating. We're supposed to be promoting interoperability. We're obviously still not there. And then burden reduction. I think we've changed the burden to another location. So maybe it's still as much for you all to do documentation, but now it's also a little financial piece in there. And then improving patient access to health information. Now, I do think this is a benefit. You know, a lot of folks say, well, we can't get them to join the patient portal. Well, that's fine. A lot of our older folks don't want to. That doesn't mean we can't as their children. You know, and that may be where we have to start marketing that measure too. The other part about this program is that it has no end date. So we talked earlier today, and you've heard us on presentations talk about traditional MIPS maybe going away, moving to MVPs. Hospital PI is not set up that way. It is a undetermined length of time. So we'll be doing that for a while. So as a snapshot for, I don't know why I'm so hoarse, sorry. I guess because I've been here all day with you all. So program objectives, it is still a continuous 90-day reporting period. Any particular 90 days doesn't have to start with a calendar quarter, April, May, it can pick any 90 days. You will submit 4 calendar quarters of ECQMs. They have to be the same set of ECQMs all year. You can't do 3 this year or 3 this first time, and then maybe the second quarter do a different set. Has to be the same. And by now, everybody should be on the 2015 Cures Edition update. A lot of folks went end of last year, but if not, you should be on that to report. And then SRAs, which Amy's going to talk about later, is nothing new. And then the Safer Gods, this is the 2nd year for that. And I've already mentioned the 60 points. We get an extra day for attestation for leap year. So February 29th, that date's already been determined. And the date is actually determined anyway. February 28th is what it is for hospitals regardless. So we have 4 objectives with measures within each of them. Nothing is significant. We do have the points of how each thing scores and how it contributes to your final score. So I mentioned earlier we had some rearranging of points, and you can see now that the focus does primarily hit health information exchange, but even more so provider to patient exchange, which is getting folks to access that portal. I mentioned TEFCA earlier too. We don't really have anybody yet approved for a TEFCA agreement. So that's the Trusted Exchange Framework and Common Agreement. A lot of you folks have heard of Commonwealth. They're probably going to be one of the first that gets that approval, but nothing's been definite yet. It'll actually make things a little bit easier, but also it works the same way as your bidirectional exchange for HIE. You just have to have it in place. There's no performance requirements for it, so you just have to prove that you have it in place and have access, and you can meet that objective. So what was once a highly difficult measure and objective to meet is now becoming a little bit easier, but it does take some work on your part of the practice and the hospital and your vendor. And then the public health and clinical data exchange, we do have the 4 current mandatory, sorry. 1, 2, 3, 4, yeah. 4 current mandatory measures, and then next year we'll have the 5th one with AUR. And then there are some eligible bonus points there if you have a 5th one in place currently now, which some folks do have cancer registry maybe, or something else in place. Here's the list of clinical quality measures. One of these is mandatory, the safe use of opioids, and then you can select from 3 others for reporting for this year. And then that last one or last 2 that are asterisks, they are new for 2023. The other thing to note about clinical quality measures, if you're an acute care hospital and you are participating in the IQR program and you're already submitting these each quarter, you don't have to resubmit at the end of the year. These will count, but critical access folks will have to submit these when they submit their attestation. So our scoring program, I mentioned earlier that it is a minimum of 60 points to meet the requirement. There are some potential bonus points up to a possible 100. Hospitals must report on all required measures to be considered a meaningful user. It's an all or none situation. So zeros in your numerator will not allow you to move forward. So keep that in mind. The legally mandated penalties are from the HITECH Act, and they continue to remain in effect. And so that's why success in this program is so important. And so I've put up here the 2 that are applicable for eligible hospitals. These are paid on your inpatient prospective payment system and then your critical access. And so this decrease of 75% applies to the market basket update for that current year. So as CMS issues out new IPPS rules, they issue out new market-based adjustments, and that's how that's reflected in that penalties. And then this adjustment is applied to the payment year for which you submitted your program. So we're submitting for 2023, the payment adjustments applied for fiscal year 2025. So here's some things to think about right now, being the end of the quarter. I don't know how well that slide's projecting, but so October 3rd was the actual start of the last 90 days available in the year. So again, you can use any 90 days as long as you meet all the measures, but October 3rd is the final date. You need to make sure that your SAFER guides and your SRAs completed, or at least scheduled to be completed before the end of the year. You need to make sure that you have the CEHRT ID for the 90-day period that you intend to use for attestation. So some folks may use an earlier 90 days. You'll need to go and visit the chapel website to pull that down. I would also suggest that if you haven't already submitted your quarters for IQR, but maybe your critical access and you're going to have to submit some data, build your files for those first few quarters and make sure you don't have zeros. It's not that it's important because of performance, but if you have zeros in your ECQ measures, you're going to have to submit additional data and paperwork at the time of attestation. And you want to know now and kind of get that resolved. It could just be a quirk in the system, or it could be something else. And then review your public health agreements. So I mentioned Live by 25. You've been in option 1, as we call it now, with your signed participation agreement. It's time to start moving forward and getting live with whatever it is that you still aren't live with. Now, I think Andrew mentioned we have several connections across the state, so a lot of folks are in good shape, but it applies to both programs. Hospitals seem to be a little faster at some adoption than maybe our practices are. So here's our timeline. So it is a calendar year of reporting when it comes to your selection of your 90 days. Attestation generally opens, we got January 1st, but it's usually January 2nd. And then you have until February 29th for this year for submission. If you did not demonstrate or successfully be able to attest to the program, there are hardship applications available. The program's a little different though in how they make that available. With our MIPS program, it's during the current year. With hospitals, it's actually after the session closes. So you have to wait until maybe the summertime to fill that application. In addition, CMS is very specific on what you can claim a hardship for. So it's not just any reason you have to demonstrate a significant hardship. And then you are only allowed 5 hardships per CCN that you can apply for. So once you've met that, once you have exceeded that 5, you can't submit anymore. It's not 5 consecutive, it is 5 lifetime. So if you reach that point, you're going to be penalized going forward. All right, so we're going to talk about 2024 so that you get a little insight into what's going on next year. So we will make the safer guides mandatory. There will be no option to report yes or no. You'll have to report yes to completing those. Hospitals have to complete all 9 of those safer guides. This is probably the biggest change in the lifetime of the program. Instead of a 90-day reporting period, we're now going to 180 days. And the last 180 days of the year is July 3rd, I think is what we said it was. I think that's what we've determined it to be. That's a pretty big deal. And for folks that are not accustomed to that, it's going to be a change. Additionally, they are adding 3 new ECQMs for hospitals to use as one of their self-selected measures. These are not mandatory like the opioid is. This just adds to the list that you have available to pick from. So, you know, fewer changes, but still several. So this is a service line that we offer. We've talked about that, you know, earlier this morning. Christine and I are your advisors for this program. You know, the ways that we help you if you're not working with us already, we do provide, review your reports, help you identify any gaps, work with you through conference calls and occasionally some on-site meetings, and get you to where you are successful in this program and give you options and best practices. So we're happy to talk with folks, you know, today or by email. Or contact info will be up, and we'll further explain how we help folks as well. So I've added a couple slides in here just as reference. This is these are links that will get you to the 2023 final rule, as well as to the 2024. I mean, it's fantastic reading. So much information in there. And then finally, I'll take any questions. And if you've seen my presentations before, I usually have a dog or a kid up there, because we need something. So this is the no-named puppy at my house. And within a few weeks, she's quickly learned her dog food is on the 2nd shelf. So I'm willing to entertain any questions anybody has. Oh, I did such a fantastic job. So here's our contact info. Like I said, Christina is online. I don't know if she's been chatting with you or not, Jared, but she's online with us. And she would love to be here if she could. So I appreciate you all. And I guess now I get to read these awards. You coming? 19 minutes. Look at me. All right. So we're going to start with our Distinguished Large Health System Award. There we go. And so we are presenting this to Appalachia the healthcare system of Appalachia. Oh my gosh, I'm so embarrassed. Appalachia Regional Hospital and all of their hospitals. Ugh. They're back there getting me right now. I'm not even going to look up. So ARH is ranked as one of the top 10 employers by Kentucky Forbes magazine. They are a non-for-profit health system operating 14 hospitals in Kentucky and West Virginia. And we've been working with them since 2021 on hospital PI, but longer on MIPS. And we have watched them work and grow as a team throughout our time together, and just seeing their performance improve tremendously. And they are such a fun group to work with. And so we're proud to report for the past 2 years, ARH has successfully attested to the PI program for all 14 hospitals, on track to do the same this year with near perfect scores. And by that, I mean in the 90s, scoring very well. And so we are very proud of them, their performance and their teamwork. They may have just fired me, but come on up, please. All right, so the next award I have is our Multi-State Hospital Partnership Award. And so we're presenting this to Rural Hospital Group. RHG is in the business of investing in small to medium-sized rural hospitals located primarily in the less populated and more remote areas of the central United States, where rural hospitals are usually the sole provider of emergency inpatient and outpatient care. So we have advised one of their hospital, Crittenden Community Hospital in Marion, Kentucky, for many years. And at the beginning of 2022, RHG approached us about adding some of their other facilities, which are in other states. So we're talking Kansas, Oklahoma, Tennessee. And so we've added them. We've provided education support, helping keeping them on track. We've created a community of practice, bringing together multiple states, acting as a collaborative environment to communicate, connect, and share best practices. And all 5 hospitals have greatly improved their performance and successfully attested to the Medicare PI program. They had folks who were also having to use the hardship application. So we have enjoyed crossing state lines. I will tell you, Christine and I have learned so much. And not only are we lucky to have K-High, we are spoiled. So I will throw that in there. So there's number 2. And so congratulations, RHG. I believe we have Reese Baker here to receive that award for them.
I'll let you two, since y'all know each other.
So Reese and I go way back.
Used to be my work wife.
Oh my gosh. Yeah, I got his real wife's phone number too. I'll have to text her. Say he did it again. All right. So final award from me, Client Hospital Legacy Award. There we go. So we are presenting Russell County Hospital with our Rural Hospital Legacy Award. Russell County has served the residents of Russell Springs since around 1980. We've worked with Russell County since the inception of the REC, so they are really a long-term client and partner with us, and we're so very excited to have them. They have been with us since the original Meaningful Use Program and has under the grant, and then we transitioned them into a sustainable model, and they have stuck with us. They have utilized nearly every one of our services, and we so appreciate their relationship and hope that we can continue to work and advise them going forward. So Russell County.
You all were my first hospital visit as well. And when I showed up there, when I came to work at the Regional Extension Center, I'm like, where are we going? And I don't think I met with you all, but I met with Monty's, who we met in the chapel because you didn't have any meeting space. So it was, yes.
All right.